Tēnā koutou, tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Chris Jackson aho. Welcome everyone to this New Zealand Telehealth Leadership Group sponsored Telehealth Forum on the use of telehealth during COVID-19, reflections and lessons. What have we learnt? Where are we going? Thank you so very much everyone who's joining in tonight from around New Zealand and perhaps even beyond, who is watching this downloaded from the worldwide interweb, and who's given up their time to join our panel as we spend time reflecting, learning, discussing how to improve what we've learnt, the lessons from COVID-19, the telehealth that was foisted upon us all at once, that we can learn some lessons, see how it impacted on our patients, how it impacted on our practice, and how we can improve and act to ensure that we improve outcomes and care for people. I'd like to start tonight by welcoming everyone along. We would like to thank the New Zealand Telehealth Leadership Group, who are the sponsors of this, the New Zealand Telehealth Forum and Resource Centre, who are the hosts, and Te Aho o Te Kahu, the Cancer Control Agency, who are the champion for this webinar, and of course the Cancer Society of New Zealand, who provide me with a role and who've been promoting and supporting telehealth initiatives around New Zealand. I'd like to introduce our panel this evening and to thank our panel for their wisdom and guidance during this webinar, and of course for the leadership around New Zealand and the world that they offer our patients. I'll introduce Dr. Claire Hardie, who is a radiation oncologist and clinical executive for cancer screening, treatment and support from MidCentral DHB. Claire had been on the Cancer Agency COVID Agile Response Team and has also led the Radiation Oncology Work Group, so has led our Radiation Oncology Network clinical services throughout this time of change. Claire has been a constant, thoughtful, calm and logical head throughout this whole time, has been a fantastic leader for New Zealand. I'd like to introduce Michelle Mako, who is the Equity Director at Te Aho o Te Kahu, the New Zealand Cancer Control Agency. Michelle and I have worked together. I've had the privilege of beginning to work with Michelle over the course of the last 6 months, who has been leading the Cancer Control Agency Te Aho o Te Kahu, in particular the work that the Cancer Agency has placed at its heart, which is partnership with Māori and true leadership and true partnership with Māori. Michelle works very closely with Hei Uhuru Mowai, the New Zealand Māori Cancer Leadership Group as well. Dr. Richard Isaacs is a familiar name to everyone in oncology circles in New Zealand. Richard is a medical oncologist, is perhaps New Zealand's most qualified medical oncologist, with his DPhil from Oxford, who has been a champion of breast cancer research, clinical trials, and of the regions, has been head of medical oncology at Palmerston North on more than one occasion, and has, of course, tended to the care and needs of many thousands of patients over his career so far. Marie Wales is the Manager of Supportive Care Services for the Cancer Society of Otago and Southland. Marie is a staunch advocate for the needs and rights of patients affected by cancer throughout the Otago and Southland region, and she is a fantastic asset to the Cancer Society and reflects the Cancer Society's values extraordinarily well, and is in regular contact with all the patients around the Otago Southland region. We have Anne Fraser, who is New Zealand's first ever oncology nurse practitioner and also a PhD candidate, also with her PhD part funded by the Cancer Society of New Zealand, and was the deserving recipient of a Cancer Society scholarship. Anne's PhD is in models of care, models of follow-up care, and has also done a particular nested study at the moment of patient experiences of telehealth during the COVID lockdown. So tonight Anne is going to share with us, for the very first time in the world, the responses of New Zealand patients to telehealth during that time. Our anchor speaker, Professor Sabe Sabesan, is perhaps one of the world's leaders in telehealth oncology. Sabe is a friend from Queensland, and he has really pushed the boat out on telehealth and teleoncology in New Zealand. Not only has he pioneered it in his own practice, in his own region, he's then backed that up with the understanding the needs for it, demonstrating the needs, and then leading by the nose the professional groups and the government through the policies, procedures, paperwork, compliance that have been needed to make this into a reality. Sabe saw the need for teleoncology in the rural community, the highly dispersed community in his network, and not only saw the need, felt it, responded to it, and led change in a structured and meaningful way that has meant that patients get time back that they otherwise would not have had, and has flipped the model of care on its head and has done so in a constructive and thoughtful way. And it's just so exciting to have Sabe share with us his experiences as well. Hopefully we can learn from what Sabe has done and replicate his work and learn perhaps even from some of the mistakes in order that we don't necessarily need to make them. Sabe is going to give us a 20 to 25 minute presentation on telehealth, teleoncology, and then we're going to move to Anne, who's going to share the patient experiences from her research, and then we'll have a panel discussion and be able to take Q&A right the way through. Thanks for tuning in. I'm going to hand over to Sabe now, who's going to deliver his presentation, and feel free to submit your Q&A through the Q&A function on Zoom. Sabe, over to you.
Kia ora, thank you for having me, guys. Chris, John, and the team, is really an honor. So I'll do some justice. So I'll share the screen now. Okay, so the topic is telehealth during COVID. I really have to talk about the pre-COVID telehealth as well. So today I thought I'll cover role and status of telehealth, use of implementation science in shaping the system, and future opportunities. I think a useful reference we managed to create with Clinical Oncology Society was the Clinical Practice Guidelines for Teleoncology. So that's available online. Just to set the scene, we used telehealth pre-COVID mainly to improve access to cancer care for regional and rural towns. And as you could see, we have medical, nursing, and allied health consultation models. This is Townsville to Mount Isa, a small town, where the model is actually teleoncology replacing face-to-face. Then you have your education and training models, treatment models, I'll come back to it. And then now COVID has changed everything, and we had to do things differently. So first I touch on the telechemotherapy and the treatment model. So even though I call it telechemotherapy, it's actually for biotherapy as well, where it can be used by other specialties. So this is the Queensland Remote Chemotherapy Supervision Model, or the QREX guide. It was based on our work in North Queensland 6 or 7 years ago. So what happens in this model? A rural nurse in a small town, with the support of the family and rural generalist doctors, pharmacy, administers selected chemotherapy agents using under the supervision of oncologists, hematologists, cancer care nurses, and pharmacists at larger centers through telehealth, so that the patient gets some sort of chemotherapy locally. And you could see in this picture, one of my colleagues and a nursing colleague supervising the administration of chemotherapy is paclitaxel and Herceptin in a town called Bowen, 200 kilometers from Townsville. So we managed to summarize our study and the safety and feasibility data and published in Journal of Oncology Practice a few years ago. You have access to. And as a result of that, it was adopted in Western Australia, New South Wales, and Northern Territory. For those who want to look at the model in a bit more detail, it is available on the YouTube. It's only a short video. It's really some of our nurses are taking people through the whole journey of telechemotherapy. So this one is the teletrial model. Obviously, we moved on from telechemotherapy to teletrials because, again, based on the needs, we identified one of the issue for trial is even for larger centers, you may not be able to have all the trials. So the aim here was connect smaller sites to a larger site through telehealth so that patients can participate in some or all aspects of clinical trials closer to home. And we also found out recently through COVID that satellite site can be actually a larger metropolitan site for rarer cancers. So it used to be again for rural regional. Now we found during COVID, some of the patients needed the medications at home. And so we actually had to do some of the trial activities at home. And the governance for that teletrial is articulated in the COSA's National Implementation Guide, again available online. The beauty of this model is that it allows many satellite sites to connect to one large site and create trial clusters. So in this slide, I summarize our data, and I actually had to do research, not just for the sake of research. And we faced an initial struggle in 2007 with the attitude of some of my medical oncology colleagues and physician colleagues slamming the role of telehealth. So I thought the best way to shut everyone down is just show them the data. So feasibility to provide comprehensive services, acceptable to patients, indigenous and non-indigenous, and health professionals, safety of chemotherapy delivery remotely, and cost effectiveness, and also feasibility to provide some or all aspects of, not all aspects, some aspects of radiation oncology services, including planning, and it also improves waiting time. But one of the most important thing I think we observed while we were serving all our patients, we saw that by shifting services to smaller towns, over time, the rural scope of practice was expanding, and then the workforce also was expanding. So we realized it's actually maybe one of the major benefits of telehealth is expanding the rural sector so that the patients can have their treatment closer to home, not just for oncology, for all fields of medicine. So this is the Teletrial pilot. Again, you could see that in the last year's Asia Pacific Journal of Clinical Oncology. What we were able to show was that by creating trial clusters, not only you're connecting or creating interconnected trial system, you're also upskilling and improving the capabilities of smaller sites that have never done clinical trials before. So now, coming to the COVID time, there's many changes happened to telehealth during COVID. Unlike rural and remote situation, now telehealth is within metro locations as well, and also done by general practitioners. Before COVID, we relied on health professionals at the rural end to be the proxy examiners or support people, but now we have to rely on family members as support persons for the patient when we dial into homes. But one of the benefits is that many family members can actually join the consultation and be part of that relative's journey. So we had recently, a lady who had 3 children in 3 different states, but all of them joined and helped the patient make some decisions. The other aspect now is the end-of-life discussions and breaking bad news conversations, which are usually undertaken face-to-face, may need to occur via telehealth. And I also noticed that a lot of specialists, general practitioners, health professionals, junior doctors who never done telehealth or never familiar with the patient are doing telehealth. So we might have to watch that space and make sure that the training is adequate to provide a high-level consultation. So this is again, as a result of COVID, this is a Herald Sun article, the phase 1 done through Teletrial model between Alfred Hospital in Melbourne and Royal Hobart, really breaking down the state borders between Victoria and Tasmania. So this is what it looks like now, the virtual health system. I haven't added remote monitoring and the other technologies here, purely focusing on telehealth. So you have the telehealth connecting the families, patients, specialists, primary care, allied health, and supportive care. So here, because we are involving families more than before, normally when the patient comes to us face-to-face, might have one escort. But now there's more family members can be there, true person-centered care, less disruption to work and family routine. And also the shared decision-making is at higher quality because there's more people involved. And now we are also doing more telehealth into primary care in the form of shared care models. Again, the quality and the strength of shared care models have improved. And also this is a fantastic opportunities for continuous medical education for both the specialists and the primary care providers. And of course, multidisciplinary care is also accessible now. So it's not all rosy. There are many ongoing issues. Technology and networks remain to be improved. The main thing about technology was really the software everyone is using. And even though Queensland Health was far ahead, their portal was clunky. So we actually had to resort to other technologies. Some states invested heavily on software rather than hardware. So they have better technology where you can have virtual waiting rooms. Coordination is an important capability. I found if you don't have telehealth coordination, clinicians will have trouble navigating the system. But unfortunately, the system wasn't prepared for. As I said before, communication skills in telehealth is an emerging area. I think we need to improve that. And one of the disappointing things was because some of the centers have trouble with telehealth, they just switch to telephones. Hopefully that will stop when they acquire better softwares. And access to vulnerable groups is an ongoing issue, and I think we've got to focus on that. And some of the perspectives we heard recently, but for me, it's actually not new perspectives. These are the complaints people made 10 years ago, and we were trying to address over time. Questions even now, can we see new cases via telehealth? Of course we can. My answer is going to be all yes, so I'm not the really trustworthy person, but I just back it up with evidence and my experience. So with Mount Isa, we started seeing new cases first 10 years ago, and then the follow-up on telehealth. When we realized we actually don't need that, we completely switched to teleoncology and replaced the face-to-face with teleoncology. So for us, new cases, yes, via telehealth. But if people have trouble seeing new cases via telehealth, they can see them face-to-face. But for rural patients, one of the benefits of seeing the new cases on telehealth is that you can actually triage the patient. If they when they come to major centers, you can coordinate the whole visit, organizing scans, other supportive care stuff, rather than patient going back and forth. What technology is best? I think a simple, easy to use waiting rooms kind of software is good, but also governments have some restrictions on data security. The other question is who needs to be on the receiving end? What about physical examination? We can have proxies, nurses, nurse practitioners, rural doctors, interns, RMOs, medical students. But if you really think physical examination is going to make a difference, then you might have to bring them, but that's not the case always. Who needs to be on the receiving end? It's really depending on what you are trying to do. If you're just talking to a patient about side effects, you don't need anyone apart from maybe family members. But if you want to do chemotherapy, you will need the nurses. And if you're going to do trials, you need the PIs. So I think it is an open-ended question. The answer is depending on what you're trying to do. The next question is which cases are suitable for telehealth? For me, this is almost like, would you ask a New Zealander which mountains are suitable for climbing? They will say every mountain if you have the right gear and setup. So again, same answer for patients. Can we break bad news and discuss end-of-life care? Of course, again, is to do with the capabilities of the other end. If the patient is happy to have the conversation with the support of the family, no one can stop us, provided we have some framework. But fortunately, a lot of the telehealth rural towns normally have a nurse or health professional on the other end with lots of family members. I think sometimes breaking bad news on telehealth may be better than face-to-face, not just because you can hang up the link, but it's just that when I see patients, sometimes they come by themselves, sometimes they have one family member, and they still have to drive home. Whereas on telehealth, I have seen many family members coming in, especially the indigenous patients. Can we build rapport over telehealth? Again, yes. I mean, I can't provide proper data, but all our health professional satisfactions were suggesting that. But people do find their partners online and marry. So my feeling is that people who have trouble building rapport face-to-face will have trouble building rapport over telehealth. So they just need to find mechanisms to fix that gap. So now telehealth is here to stay. So there are push for reimagining the patient experience during COVID. And there was, I'm glad that Anne is doing the PhD on this. I'm looking forward to listening to that. There was one article I found here. One of the main summary was that the area for improvement is actually interpersonal communication. So I think the training and education need to be part of the package for patients and health professionals. So the current frameworks for doctor-patient communication and end-of-life and breaking bad news apply to telehealth with attention to technical considerations. And we wrote a piece in MJA Insight if you want to have a look. And this is the screenshot of the MJA Insight. So the summary is that, again, it's really common sense. Even if you forget that you're on the screen and thinking that the patient is actually on a real patient, you will do a good job. So establishing rapport, relationship, and trust. Same as face-to-face. Introduction, establishing eye contact by keeping the eyes at the level of the camera, talking non-medical stuff, and asking about fears and concerns. And the transfer of information, again, it's the same as face-to-face. Speak slowly, non-technical language. One other thing telehealth allows is actually you can now use electronic means to share information like online whiteboards, sharing screens to show medical imaging and pathology reports. Summarize the consultations and check that they have understood. Send a summary to the patient and the GPs. That's what we do now. And then always ask the patient whether they have any questions, and then use it as a teachable moment and highlight the importance of vaccination, hygiene, physical distancing. And then for end-of-life discussions and discussing breaking bad news, there are frameworks, prepared or spikes. I like the prepared because it's a bit more detailed. All we have to do was to add the tele component. So it's tele-prepared. So the T is technology is adequately set up for connectivity, audio, and video. Extra time allowed for establishing rapport. L is local support, including family members and health professionals. Sometimes you have community nurses, medical students, volunteers. And the E is for establishing eye contact using correct camera placement and lighting, and also ensuring that you can capture the emotions and facial expressions of the people. And as usual, after these complex conversations, always check a few days later to make sure that everything is addressed. So how do we maintain some of these benefits? I think we have to keep developing holistic and value-based telehealth systems for all citizens, regardless of geography and provider setting. So this is where I try to incorporate implementation science to make sure that I haven't missed any steps, key steps in implementation. There are many implementation frameworks. IFARS is one of them. The successful implementation is a function of facilitation, innovation, recipients, and context, usually. So in terms of context, when we are implementing this kind of system, we just have to see, is it local, is it organizational, or is it system? I think in terms of system now, because governments have taken the step, already telehealth is aligned with their priorities. There are incentives and mandates, so it's really game on. So now it now depends on the organizations and local leadership and support, the culture, history of innovation and change, and what kind of mechanism and levers we have within those organizations. And at least within organization, you can align with strategic plan and align with government priorities. Then if this is a function of innovation, recipients, and facilitation, innovation again is sorted. It is proven, is used now. So we just move to the recipients. We just need to work on clinicians, managers, health service level, and system level, and touch on their motivation and values and beliefs, existing networks, collaborations and teamwork, finding champions, using clinician powers and authority. Facilitation is really, I think in this situation, there are project officers, but I think the most important component to make it easy for clinicians and patients is actually telehealth coordinators. And then the outcome measures would be your process outcomes, patient outcomes, and then what are the legacy outcomes that in terms of system capabilities. I just want to touch on a couple of key principles. I found it useful. It's really driving action through purpose, and many of you would have heard about the golden circle, Simon Sinek's model. We tend to talk about the what all the time. So I found when I talk to a lot of colleagues, rather than talking about telehealth, we start with why telehealth and then talk about the solutions. And it seems to, the purpose seemed to resonate with people rather than the technology itself. And also the role of clinician levers. So these are items or mechanisms clinicians can use, the power you get from being an advocate when they face barriers to implementation, but provided that they have fulfilled the criteria of implementation frameworks. So we have used this where throughout all our models, when we face barriers, it's all to do with advocacy for improving disparity in outcome, compliance with guidelines and standards, connection with consumer bodies, and you have a great lever here is the Cancer Control Agency and Cancer Society of New Zealand, and also political connections and escalations. So how do we then take telehealth to virtual care? I think there are so many opportunities. If you look at the recipient side, rural hospitals, we can do remote monitoring, telesupervision to enhance the rural scope of practice and capabilities. Patient and families, we can add remote monitoring and incorporate PRIMS and PROMs to provide timely care at home with family support. General practices, shared care models, advice services, health pathways, really GP enablement and hospital avoidance. Teletrials, same benefits. Nursing homes, normally oncologists, unless you're a radiation oncologist, medical oncologist, don't get involved with nursing home patients, but there's telesupervision and remote monitoring, hospital avoidance. That would be useful for a lot of other non-oncology specialties as well. Indigenous health services, again, to build community capacity. Hospital in the homes, you add remote monitoring, enhancing scope, partnership with primary care, care at home, and hospital avoidance. So COVID has so this is my last slide. COVID has precipitated the need for telehealth as a social distancing measure. Uptake has been increased and many flow-on benefit has been observed as a result. Lessons can be useful for redesigning the health system for it to be efficient and patient-centered. System-level intervention at policy and clinical levels are required. Implementation science frameworks can inform sustainability mechanisms and quality improvement approaches. So thank you again. I'll finish up with this slide. And while you are freezing, it's actually warm here. So warm greetings from Townsville, and thanks again, and thanks for listening.
Well, kia ora, Sabe. Thanks so much for a fantastic presentation. We've got some questions flying in through the Q&A there. Thank you, Sabe. We'll pick up on many of those exciting themes after our next section. Again, just going to introduce Anne Fraser, again, New Zealand's first oncology nurse practitioner who's doing her PhD in patient-centred models of care. Anne has been doing the most important thing of all, and that is asking people what they want and how they found it. Anne, I'm going to hand to you to speak for a few minutes on your research, the conduct of that and your initial findings. So grateful that you're able to share your results, which are first time ever aired here tonight. Anne.
Thanks, Chris. You're making it sound a lot more exciting than I'm going to, but I appreciate the enthusiasm. I was looking at virtual models of care as part of my PhD, and obviously when COVID landed and we ended up in level 4, everyone moved to telehealth, so it seemed a good opportunity to ask patients how they experienced that. Chris, do you have any specific questions for me, or do you want me just to chat through what I found so far?
Take us through, Anne, what your particular research question was and what your research found.
Yeah, sure. So I just, we ended up doing an ESTER study interviewing 30 advanced stage lung cancer patients, curative intent patients as well, and patients who were just under surveillance, just to get a view across the board how people were experiencing going to a more virtual model. And we had around 40% of those patients were selected as Māori patients for specific feedback. The main themes that came out of it closely reflected the wider literature that we'd already looked through. So issues like cost, not just costs that the patients experienced, but also how they perceived cost within the healthcare setting. Savings on time, not having to leave work to attend appointments, not having to travel across the region to attend assessments. Patients talked a lot about relationships and how it had changed, the experience had changed the relationships not only with their healthcare providers but also within their whānau. Patients talked about seeking help and how that improved their sense of independence. And we got some good feedback about the Cancer Society nurses in there, just so you know. Patients talked a lot about the physical exam and the experience of not having CT scans, but again, that was viewed really positively. Most patients, as Sabe's mentioned, they hadn't actually been experiencing physical exams in their assessments, and so that wasn't a specific concern for them. Again, with the CT scans, what came out of that feedback was that a lot of patients didn't even understand the CT scans when they were explained to them in clinic. If they saw the images, they found them quite overwhelming. And a couple of patients mentioned that it could be useful to have Zoom and be able to share those CT images, which with this lockdown, level 3 lockdown in Auckland this time round, I've offered that to quite a few patients, and that's had variable responses. Patients also talked about just basic issues around technology and whether or not Zoom would have been useful. So really similar to the themes we've heard tonight. I did ask the patients specifically around those issues about breaking, I'm not so keen on the term, but breaking bad news, how they found about having palliative intent conversations, and also issues around having a new patient assessment via telehealth. And again, patients seem to be quite favourable. I was really interested, Sabe, in your particular feedback about the palliative care conversations. Patients really talked a lot about that, of being able to have those conversations in their own environment, at home, with their family and whānau around them. Usually in the clinical setting, they're travelling to those appointments on their own. We're delivering that news to them in isolation, and then they're having to drive home, usually quite distressed. They often then can't remember what they need to tell the family or the whānau when they get home. And so actually doing it via telehealth or Zoom, they could have multiple people come into that conversation from all over the region or country. We had people phoning in from Australia, America, England, and it worked extremely well.
So, and can I check with you, in your region, were you delivering most of your COVID care via telephone or by video consultation?
The first time around, it was all by telephone. This time it's a little bit more mixed, but majority is just over the phone or with teleconference, not video conference.
And so, and did people identify any differences in experience or acceptability between telephone or video consultation?
Well, that group of patients is very small, so and it was a bit ad hoc, but where people did like the video or the Zoom, we tended to use Zoom. They like being able to share the CT screen. So if you were going through the images, they quite liked you being able to share that. And some people found that really useful. They're very visual. They wanted to be able to see how much a lesion had shrunk or grown and where it was specifically in their body, particularly if they were experiencing pain in a specific area. It helped them to make sense of what they were experiencing.
So was there, did you get a sense that people preferred video over telephone, or it was just again dependent on?
It was very dependent on the person. I asked people specifically as we went through the interviews. A lot of people didn't want to do video conferencing. They felt it would be too complicated. They actually enjoyed being able to sit down and, as they expressed it, just having a chat over the phone with someone. It felt less intimidating. They felt more relaxed. We did have about maybe 3 or 4 patients who said they preferred face-to-face. But one of the caveats around that is that a lot of our patients had already developed a relationship with the team. So when we were calling, they could picture who we were and they could imagine who they were speaking to. I think that was more challenging where a relationship hadn't already been established.
Thank you, Anne. I'm keen to bring the panel back on online. So if I could get all the panel, please, to turn on their cameras and their microphones. And that's fantastic research that you've been leading as you work through your PhD, which obviously had to change tack very slightly during COVID as well. So again, I think sometimes these crises can lead to some absolutely fantastic outcomes, actually. And the insights that you are already sharing and that you'll be able to write up and provide for all of New Zealand, I think will be very important as we learn from this experience. That's been just so key. So we've got the panel up here. I've got some questions coming through. First of all, Marie, from your perspective, a lot of the population who you support are rural and remote, who may not have good access to internet connectivity, for example. What are some of the barriers and engagement issues around telehealth that you've experienced through people you connect with?
Well, we think telehealth is a great platform to enable people to continue living without the disruption of travel for their family and their friends. However, out here we do find there is a lot of connectivity issues because people are living rurally, so they don't have that stable internet connection. Working with Southern DHB, we've set up that North Otago drop-in hub, which we've found really good because it just means that people can actually travel a short distance, but they have the security of knowing that someone has set up the telehealth for them so it doesn't cause that added stress. We've also been able to create a warm, welcoming environment so they can actually have a cup of tea and be quite relaxed. And interestingly enough, we've had 100% uptake for having a support person in the room with them. And I think that we had a gentleman, for instance, who lived out in the Central Otago area. He was a Māori gentleman and he was 75 and he was deemed non-compliant by the DHB. And what we found was with the telehealth that he was scared to travel down to Dunedin, which was a 7-hour trip for a 15-minute appointment. And so by connecting him with a wraparound services, because we are assessed to psychosocial needs, he has become so compliant. He's such a lovely man. We've given him a patient navigator. So I think telehealth is fantastic, but you also have to look around the psychosocial needs of patients, especially in a rural area. And by wrapping around some of those supportive care needs, you get people who feel suddenly empowered to make informed decisions. Because I think Anne pointed out that people learn differently. We've got visual learners, we've got auditory learners, and we've got people with different levels of literacy, health literacy. So I think we've got to look at different pathways for the different people and the different needs that we're meeting. And I just have been absolutely thrilled with working with the patients out here. And that's why I think it's also about connecting on with the community service providers that are out there that may be non-medical, but they actually have the capacity to actually connect people's services, can make them, I think, more successful in their treatment plans. And we've found that having a support person in the room has been fantastic because it's enabled people to have the opportunity to ask questions. But during COVID, the fascinating thing for us was a lot of men uptook the online support groups, men that we were really hard to reach in our normal day-to-day life. Actually, I think felt really empowered to join support groups because they were more in control online as opposed to being in a room. So I think it's not a one-stop shop for everyone. That's what I see from my perspective out here in the rural areas. So, yeah.
Great themes there, I think, Maria. And in particular, I think the idea that you can just drop in a technology without having thought about it more in the wraparound services is a crucial point too. And in particular, when a lot of those services are concentrated centrally rather than ensuring everywhere. Michelle, often we talk about intersectionality of need as well. Of course, with Māori having comorbidity, having rurality, having access to technology issues as well, acceptability as well. What are the issues in particular for Māori as we work towards an environment where telehealth is more prevalent?
One of the things that we found really interesting during COVID was the impact on not just people's ability to travel, but the actual travel infrastructure. So there was a whole range of challenges around the infrastructure not being readily and widely available. So suddenly you have people who maybe were relying on a friend to stay with while they're having their treatment became really unable to access that. So I do think the telehealth service has given people alternatives to travel. I think the comments that Sabe has made around being able to create closer to home hubs is really important. I guess the other some of the other challenges to think about for Māori is again that idea of having whānau support, but also being able to access mātauranga Māori and kapapa Māori approaches to the way they receive their care. So we're really interested in looking at how we support hauora providers. And I said there was a question there about the role of marae. How do we support hauora providers in remote and rural regions to establish places where whānau can go, where not only are they able to have their whānau and the environment is familiar, but if they need to have karakia or waiata or whakawhanaunga or other kapapa Māori methodologies of connecting to their treatment and their care, those are easily delivered in the community and in the settings. And as you mentioned, that with the intersectionality, we had the challenge in our house of having an older person in our home during COVID, and being able to have my husband and I sit with our mum while she's getting, quite complex treatment and care over the phone was a real, we would never have been able to do that previously because she lives in a remote farm in a rural community. So again, having access to shared knowledge, we were able to share some of, I guess, the information with her in ways that were more accessible.
Oh, fantastic. Richard, you've been using telehealth as a provider for quite some time. How's it changed over time, and what are the current challenges in the New Zealand environment?
Well, we started we had video units established in a number of the peripheral clinics that we serve a couple of years ago, and we got used to working in that medium. Patients would still have to come to the base hospital to be seen, and we weren't using Zoom or telephone at all at that stage. And then COVID came along and it really made a big difference. We were suddenly faced with 40 patient clinics being cancelled in the peripheral centre and us being unable to attend. So we decided to move to a telephone assessment for chemotherapy and follow-up, and we really did the FSAs by Zoom. I think it's almost as reliable as the video units we were using. It had a lot of advantages for the family in that they didn't have to travel. And we really couldn't bring people in for the clinics because of social distancing in the clinics. I mean, the numbers that we could fit in there were greatly reduced, so it was really quite a challenge. But it's worked quite well. I'm quite comfortable doing Zooms for new patients. I think seeing people makes a huge difference in your assessment. It may not be as good as seeing them face-to-face, but you get a good idea of performance status and whether they're fit for treatment. So I really value that opportunity to see somebody by telehealth. One of the other big advantages that's happened is that we've been able to establish peripheral centres in clinical trials, or include them in clinical trials now. And we've got consent or approval for patients to be consented and monitored in peripheral centres, so increasing accrual and giving trial opportunities to those patients. We're now looking at how we can incorporate telehealth in day-to-day stuff. I mean, I find telephone assessments quite more than adequate if we're following patients who are quite stable, and we're mainly following blood tests and symptoms. And both Zoom and telephone can really be a filter for deciding which patients need to be seen in person, either at the peripheral site or back at base.
You were using a very mixed model there by the sounds of it, Richard, with a mixture of hub-based VC units, home-based Zoom and internet connections, and then telephone as well, so mixed model of delivery during that time.
Yeah.
Claire, what was the radiation experience like?
So I'm obviously based at the same centre as Richard, so we have a similar experience. Although predominantly during COVID, it was mainly telephone consultation for radiation oncology. I agree with Richard that the ability to actually see someone in via a video link, either by Zoom or in the base hospital, has advantages, because you do get a better feel for their performance status, and also it possibly is a bit easier to build a rapport for a new patient than over the telephone. Having said that, certainly when we have done telephone new patient appointments and follow-ups, a lot of the time the patients have found them satisfactory. As has already been alluded to, it's reduced time off work, it's enabled them to be at home, have support people, have people dial in. But it isn't right for everyone. And although obviously telehealth is a fantastic option for us, it is also one that has to be in addition to a standard clinic consultation, where that may be the most appropriate model to use, particularly in patients where there may be hearing difficulties or sight difficulties that might make telehealth a bit more challenging.
And Claire, has it gone back to business as usual now that we're out of lockdown level 3 south of the Bombays?
No, not quite. I mean, we were doing telehealth anyway. So as Richard's already alluded to, we were doing this pre-COVID. Our levels post-COVID are higher than they were pre-COVID. They're not as high as they were during COVID. But I think what COVID has done is that all the clinicians now have seen the advantage of telehealth. Some were quite skeptical, and as Richard's alluded to, the Zoom consultations particularly have been really, really beneficial. So I think what we've seen now is a much more engagement with telehealth as a technology and as an option for our patients. It now comes down to ensuring we're choosing the right patients and the right mode of consultation for them.
I was listening to a podcast the other night with Fran Boyle from Australia. You all know Fran well, I'm sure. She was talking about Zoom fatigue and the increased activity in the frontal lobe that's required for a telehealth consultation, and saying it's perhaps even more exhausting than a face-to-face. Yeah, has your experience been with video consultation that it has a different impact on you as a provider?
I think I'm probably more efficient than I would be in an in-person consultation. It does also give you more flexibility. If you ring someone and for whatever reason they're not home, I might just call them later in the day. And I think one of the questions in the Q&A is around that. And I think it does give us more flexibility with our potential clinic times. But no, not fatigue particularly, not at this time.
Hasn't made a big difference. Sabe, coming again to the impact that telehealth has had on models of care and how it's been delivered, have there been a change to the idea of morning clinic, afternoon clinic, midday meeting? You know, that locked in stone model of medicine delivery, has it changed?
Yeah, I mean, the timetables haven't changed, but I think, as Claire said, it has given us the flexibility to adjust. You know, sometimes if you have some patient on telehealth, you might actually finish your standard, and then, but it tend to eat into some of those non-clinical times, but it's give and take. But we tried to stick to and also the MDTs were all online anyway, so really we didn't have to change the schedule, but just the medium. And also I'm finding even our departmental education meetings, people are actually attending more, because they could just do it from their clinic room. So sometimes people go home early and still dial in. So I think these few things have changed.
Yeah. And you work in a big department in Auckland. How have you found when people are working remotely, what have you found, or has there been any impact on departmental culture as a result of there being more people working from home or by that remote medium? What's it done to the environment?
Well, I guess I can only talk about it from my perspective within the lung and melanoma teams, but when we were in level 4, we got split into different pods to try and break the tumour streams up, because obviously they were worried if, you know, if everyone, say for instance in the lung stream, were working together and someone got sick, the whole team would go down and there'd be a bit of a challenge to manage patients. So what was lovely about that was you ended up working with people from other tumour streams that you just hadn't seen for maybe years. And it was really fun catching up with people, seeing how people practice clinically. And I found developing those relationships really positive. There's a whole piece of work going on at the moment about clinicians' experience within Cancer and Blood at Auckland and how they found the way that we managed the COVID pandemic with level 4. And I think it's bringing out the just huge variability in the way people coped and how people found the experience, just even the way people managed technology. But my perspective was I found it really positive and I enjoyed engaging with people across the department I hadn't had a chance to before.
Access to technology, was that an issue for some patients?
In Auckland? No, it was pretty straightforward because most patients we phoned. I don't know what other people's experience was, but level 4 was relatively straightforward. When we got to level 3, and certainly that's what we're finding this time round, is that patients aren't always home. And so going back to that point around do not attend, some patients will feel that they can, you know, that they won't necessarily be there for their 11 o'clock telephone call like they would be in clinic. So they might be off at the shops, or we had quite a few patients who were in the queue for Burger King when it opened under level 4 to level 3 last time. So, you know, that made it a bit challenging to pin people down, but we had very few people having actual true telehealth video conference sessions. So I don't think we had that kind of challenge with technology.
Thank you. Sabe, are you guys using much telephone consultation, or is it almost exclusively video consultation?
No, it is definitely mixed. Same as Australia. Some centers in Newcastle, I think they are all almost 100% telephone. But certainly our centers, we have mixed, because I think again, there's some patients actually still have, they don't even have mobile phones, and so then telephone is easier. And also what happened, they invested heavily on hardware with a view to rural health, but this means, and then we can't use Zoom in Queensland Health, apparently for some digital security, and definitely no Skype. So you actually have to rely on their portals. So, and they're not that easy. This bureaucracy always come and manipulate the system.
Yeah, interesting. I want to address that question specifically around security. Marie, from a patient perspective in particular, how concerned are people about Skype and Zoom and health information security, or is that something that bureaucrats are worried about?
I think it's more the bureaucrats that are worried about it, actually. We haven't encountered any problems with that. In fact, we do a lot of education around the patients so that they know that they are in control of their information. And we do a real robust consent process when we're doing telehealth with all the patients, but it's an informed process. I think a lot of people think you could just get a patient to sign a form and that means it's informed, where it's not. A lot of people need to actually understand what they're signing up for, what they're coming to, and how that information is going to be used. So for us, we think it's about, again, behind every diagnosis there's a person and there's a life behind that person, and so it's assessing the needs and the different environmental factors, their social factors, their cultural needs, and actually understanding the person. And when you understand the person, I mean, I think the success is around the patient experience, and we've found that you get to know the person, you get to know their needs and their issues, and the barriers slowly break down, and then you find that people flourish because they feel empowered, they feel informed. And consent and confidentiality is just one of those things. Working for the cancer side, I get a bit frustrated when, as a registered nurse, and I'm working with patients, I get challenged all the time by the clinicians and the DHB about confidentiality, and it's like, you know, we treat that with the utmost respect, especially in rural communities, because a lot of people are very vulnerable, saying, you know, does everyone know I've got cancer? Are you going to tell everybody? So we really do make a real point for patients that we're working with, that we respect their rights to confidentiality, and that this information is private, and that they should always be in control. And I think telehealth is exactly the same. So that's why when we do a telehealth hub, we ensure the environment's confidential. There's an external entranceway that people can come and go in, so there's no conflict there for them. And I think it's all, again, just talking to the individual, finding out what the needs are of that family and that whānau. So again, to me, a person.
How you set that up. Michelle, do you think telehealth reduces or increases inequities in health?
It can go either way. I was actually reflecting on the comment around access to technologies in homes. And I'm really aware that we do have some real technology issues in Māori and Pacific homes. So I think we are going to have to think a bit carefully about how we do that. I do think the hub model, particularly where you've got rural connectivity issues as well, is probably going to be a really good alternative option for those who can't access internet at home. But I did reflect, my husband actually works for education, and they've been responsible for distributing 25,000 devices into houses for children who need access to digital technologies. And I do think we can kind of tap into some of those other activities that are happening that bring technology into the homes to try and share that for the whole family. I guess the other point I'd like to make is around being really careful around with digital manuhiri, when we go into a Zoom meeting or a phone call in a person's home, and we've stressed this a lot in a board that I'm on for a school, around you're going into the private sanctum of people that they don't normally share with you. So it is also about making sure you've got the right safety mechanisms in place, because people have complex living arrangements, and we need to make sure we're thinking about that when we're entering their homes as a digital guest.
Yeah, absolutely. That maintaining that privacy, particularly if people don't have their own private spaces with more shared spaces, and they can be very challenging. Yeah, Richard, I've got 2 more minutes left, so I'm going to try and stick on time. Richard, tell me what you think New Zealand needs to do next. What are our forward steps here from your perspective?
I think we need to explore which patients are really appropriate for telehealth, because assessments by telehealth are more efficient, not only in the time that they take, but they save an enormous amount of travel for patients and clinicians. For us also, when our peripheral centres have surges of new patients, or, you know, there's an excess of patients, it's a great tool to see them from base. And I think if these approaches could be incorporated into our standard practice, that would enable us to cope with those surges and look after people more effectively.
Thank you. Sabe, having been through the process yourself and having led that, and looking across the ditch to a country which has got telephone-based telehealth with occasional Zoom and Skype, what advice would you offer our community as we move through the next 12 months?
Yeah, I mean, it is hard in terms of system change. You know, it's certainly, you know, the technological components and the education components. I think it's a multi-level approach. That's why in that slide I put system level, local level, organizational level. And I think if you make telehealth as an option, as part of standard practice, as Richard said, I think things will fall into place because there's a need for it.
So maintain that focus. So again, out of great adversity sometimes can come great success and great opportunity, and COVID-19 could be that encouragement that we need to think about a new model of care, one that must be patient focused at all times, one which is focused on reducing inequities, not increasing them, one that improves and enhances quality of care and accessibility of care, and therefore uptake and accessibility to our community. one which maintains human dignity throughout the process of the doctor-patient and whānau relationship, to ensure that we continue to wrap around people completely and look after all their needs, not just making sure they get the right drug with the appropriate dose reduction and enrolment onto the next clinical trial, but one which fundamentally has human dignity and care at the very centre. I'd like to thank our panellists for their time, preparation, experience, learning and wisdom here. Thank you for your wisdom and sharing your thoughts and insight. To all of the participants who stayed on for the entire time tonight, thank you very much. And one final unashamed, unabashed plug: tomorrow is Daffodil Day. The Cancer Society of New Zealand is our oldest New Zealand cancer charity, and we need your help more than ever to ensure that we keep looking after the patients in New Zealand. To all of our friends in Tamaki Makaurau, who are still in lockdown level 3, our hearts are with you as you carry the weight of the team of 5 million at the moment. Kia kaha, and thank you so very much, everyone, for joining us tonight. Thank you to the Telehealth Network of New Zealand, the Telehealth Leadership Group, for arranging and supporting this. Thank you very much.